Hi, Dr. Jervich here, as part of our ECHO COVID Action Network program with our continuation phase for quality improvement. I just want to give us a few minutes here for getting everybody signed in. If you haven't done so in the chat, please put your group's name and affiliation so we can always keep a double track of that. And I just want to mention that hopefully we'll be getting another group of nursing homes to join this, what we call the continuation phase of the program. So we've had three groups. Yeah, oh wow, you got a slide in there, Sarah. Great. Sarah reads my mind, so if anybody sees slides that suddenly show up, it's because she's already read my mind and has gotten this put together. So thanks, Sarah, for that. But the point is that we've had three waves of nursing home trainings, and the third wave just completed. Have just completed their first phase, and so they'll jump in on our phase two. Just as a reminder, phase two is what we're planning to do is go in monthly cycles around a different topic for quality improvement that's associated with either patient-centered care, which is the one we've done for May. The next one is safety, and we decided to do fall prevention. So that's quality improvement under safety. And then the other quality improvement is quality care measures. So those come under the aegis of choosing wisely. Just to give you an example, in my clinic yesterday, actually a couple of lessons for our doctors in training. One was that an 81-year-old lady was on Lasix for lower extremity swelling, and that's one of the indicators of not using what are called loop diuretics. You really should not be using those to treat venous insufficiency. It doesn't work, and it actually puts the patient at risk for falls, which is in part what we're going to be talking about today, getting jump started on our next quality improvement, or PIP, centered around falls. So I just want to remind everybody that as we're wrapped up our May sessions, we were focused on patient, or resident rather, isolation and loneliness. And so we want to maintain the interventions. I think some of the PIPs are still ongoing, and we're still waiting for some results from everybody regarding their particular project. But again, this is a communal setting. It's like, the hippies. We're all together trying to do something together, and so the PIPs are meant to be shared in a communal way, and you can pick and choose parts of these interventions that may work for you. And quite honestly, if some of the interventions don't work, we may want to not discard, but probably not use those going forward. So that's the whole point of doing these PIPs, is to see what works and what does not work. Sarah, do you have the agenda for today? Okay, so yeah, thank you. We'll go back to those questions there. But so today, basically, we're going to have the part two of dealing with at the leadership level of dealing with stress responses, and both for ourselves and for our staff. I don't know if I'm reminded of one of my colleagues at Stanford, who's one of those what they call C-suite type individuals, a longstanding manager, clinical manager, and just right towards the tail end of our pandemic COVID surge, he took a week off, and he says he didn't realize how stressed out he was during this whole process, and that wasn't until he took a week off. And I said, "Oh, you only took a week." I said, "You probably need 3 weeks to decompress from those kinds of events." And quite honestly, we're all continuing. I saw a lady yesterday with COVID toes, 80-year-old lady with COVID toes. So it's still showing up. I mean, it's not like this has gone away for us. So, you know, they're just, we need to be reminded of that. But importantly, to maintain a high level of resiliency, in part is what the whole point is. And then we want to go over the QAPI at a glance, and how to convert our projects into a more systemic action, and then try to come to some sort of conclusions about our social isolation PIPs here. You can go back, Sarah, to the previous slide there with the questions. So I don't know if anybody has any thoughts about walk rounds. Did anything exciting and different show up in your walk rounds? If so, please put it in the chat box, or if you want to unmute yourself and just let us know. I always do walk rounds in my clinic where I'm trying to identify which paper dispensers don't work anymore. It's like, believe it or not, Sanford replaced all of its paper dispensers in the clinic, and quite a few of them don't work. So brand new items. Okay, well, if you have any thoughts about your walk rounds, just a key point that that you learned from that, that would be fine. The other question we have is that we were taking a vote on the 5 Ws, right? Was it the 5 Ws, Michelle, that we were talking about versus the fishbone? See, you're trying to find
Sorry,
the unmute.
I couldn't find my unmute. It was actually, yeah, the 5 well, yeah, the 5 Ys. And then because there was, you know, some discontent with that fishbone, I did throw in a whole bunch of other RCA tools in there. And so you had said on the last one that maybe that'd be a good PIP for folks to just take a look at all of those and see what they preferred. So we threw that in there to see if anybody talked through it or looked at them.
Yeah, exactly. So you sent that out by email to everybody, right?
I believe so.
Okay. Yeah, so if you did not get your email regarding the tools for root cause analysis, get in touch with us and we'll send them out to you. And what we were, just as a reminder from last week, we were encouraging folks to sit down with their QAPI committee and decide which of the root cause analysis tools they would adopt going forward. Like I say, I've been pretty enthusiastic about the fishbone analysis, but some folks have been using you know, the other versions, the you know, the 5 Ys, and that's perfectly fine. But so like I say, this just as a reminder, so next week, if you haven't had your QAPI committee meeting to discuss that, or if you have not been able to distribute the half dozen or so tools for doing root cause analysis, please let us know. We'll get those sent out. And then next week, we'll kind of get a, maybe we could do a poll, Sarah, just, you know, asking which of the tools were adopted. All right, good. So we can move on to the next part there, the video. Oh, the books. I should mention, yeah, we're ordering the books. This is in back order, and for those that want these books, we will purchase them for you and mail them out to you. I actually have my copy here. I don't know if you can see on the. Yeah, it's hard to see on the video, but I've been looking at it. It's reasonably well written, but like all quality improvement, it has its own language, and I always find that you know, it's like learning Spanish. You know, you got to kind of learn quality improvement language. Once you learn it, it's not too bad. So, okay, next slide, please. So we'll move into our video here from the Institute for Healthcare Improvement.
the video. I just wanted to throw in when y'all were showing that book. One of the books I really enjoyed when I was in the facility was If Disney Ran a Hospital. Now I know it is hospital based, not nursing home, but if you recognize that there's an opportunity for improvement and just like the positive culture, which there may need to be a little re-up after this pandemic, it's really a good book inside.
The body scan. If you could literally scan your body top to bottom and really think about and feel inside of your body, where is the discomfort showing up for you? There's a great analogy called touching your stress response. Really intentionally paying attention. You guys, this is key to increasing our emotional intelligence. We can't change what we don't notice, but if we can bring more noticing on board and being aware of what we're feeling in any given moment, that's what's really important to being able to be more in charge of how we respond. Think of it when you catch your stress response, like coming up to a yellow light at an intersection. Hopefully when you see the yellow light, you think, oh, it's going to turn red. I need to slow down and I know I'm going to have to stop. So another analogy of your stress response is when you begin to feel, and I'm going to show you lots of examples in just a minute, when you begin to feel these sensations of being overwhelmed, your body is doing a wonderful thing for you. It's actually giving you the signals to say, hey, there's something not quite right here. I need you to slow down and be prepared to stop. It's giving you a signal. So take a look at these two categories. These are, first one, physical, second one, behavioral and emotional. And as I just talk through this slide for a moment, jot down which ones resonate for you. When you are feeling overwhelmed or stressed or in a state of distress, whatever words make sense to you, what happens physically? Does your breathing change? Does it become typically more shallow, or is it like you're hyperventilating? Does your heart rate go up? Do you clench your teeth? Does your tummy hurt? Are your shoulders, up at your ears like this? Is your face crease? Muscles are tense. And behavioral and emotional, do you just feel this anger and this desire to blame others, and you're just scared and irritable and exhausted? Which of those resonate with you? There's a third category from the cognitive symptoms of overwhelming distress. A lot of this is around fear. Fear of losing control, fear of not being able to cope with what happens, of being injured or even death. Sometimes we can have a frightening experience, and that image and that storyline just plays out over and over in our mind. Our attention is narrow, we can't focus well, and we have difficulty reasoning and making good choices. So this would be a good time where you could have a discussion of, where does the stress or overwhelm show up in your body? You could pop those right into the chat box if you'd be inclined to share. When you catch your stress response, really what happens next? And I'm kind of leaving you with a bit of a cliffhanger for next week's material, because next week we're going to talk about the correlation of the stress response with something I'm so excited to bring to you if you're not yet familiar with nonviolent communication. So this next topic, we're going to bring all that together in ways for you to use this awareness of the biological stress response, how it shows up in your body, and then what we do with it next. Before I close this week's session, I would like to do something a little bit different. I want to introduce you to something that you may actually already be familiar with. This is the Primary Care Post-Traumatic Stress Disorder 5, PCPTSD 5, a little easier to say that. This is a screening tool. It is validated, it's reliable, it's got all that good stuff behind it. When someone would say to you, which tool do you use to screen residents for trauma? This would be my choice, my first choice. There are several tools out there, but this is one that I would definitely go to. And I want to suggest something to you. What would it be like if we had an environment where we could actually screen staff for trauma? That we could screen staff, not just for trauma, however, but symptoms of trauma, and that we could use some of the same tools that we use for residents. What I want to point out here is that when we talk about screening tools, I'm concerned that sometimes people might get concerned, well, if I start doing screenings, then I have to do therapy, and that's not the case. Those of us working in nursing homes, we are what we call generalists, unless you have specific mental health training around the field of trauma. All of us would be considered generalists. We can receive training and do something like the PCPTSD-5, whether it's with residents. It does require training because when you open up these topics, you have to be able to talk about them, but you don't have to assess and treat them. That's what the specialists are for. So these are the simple 5 questions on this screening tool. Just quickly, in the past month, have you had nightmares? Tried hard not to think about events or avoided things? Have you been on guard or watchful or startled easily or felt detached or numb? Feeling guilty or unable to stop blaming yourself for the event? These are the symptoms of a traumatic event, possibly. So what I want to say is, would it be possible to somehow weave this in or at least make this tool available to staff, or even them to do their own self-assessment to say, hey, I might have something going on here that I might need to reach out for help. And then in your nursing home, you could have a resource library and have things available for staff that when they needed assistance, they know that it would be out there. Who in your community could you partner with to provide mental health care services? Do you have an employee assistance program? So what's available and how can we get some assistance to staff? The other thing I want to share with you is the worksheet to supplement the PCPTSD-5. This is developed by a colleague of mine, and the idea here is that it was overwhelming to remember all the different signs and symptoms of trauma. What she did here was, based on some other work, she put together this worksheet, and as you can see here, it says possible delayed emotional reactions, physical, cognitive, behavioral, and existential. So all of these things here, it's another wonderful tool here that we can use with residents to really look at the current symptoms of trauma, not so much going into the in-depth story of the traumatic event, but in other words, how is it affecting the person now, today? And then you'll notice the source. And I just want to point out why that is there. If you were using this with residents who were not perhaps able to be fully present, or they had some cognition issues that they couldn't participate in this level of screening tool, you could maybe ask a family member or another staff member, and that's what the source would be. But I'm inviting you to consider how we can use the tools that we have readily available for us to use these tools to help our staff and their well-being. So with this, I thank you for sharing your time with me. I do look forward to next week's discussion of feelings as they relate to basic human needs, and I get to talk to you about nonviolent communication and the connection to well-being. Thanks, everyone.
Very good. So I tried to put into the chat a little cartoon diagram of body language and stress, but I'm discovering that the chat room doesn't allow for pictorial delivery. So anyways, the point being, though, is that I think part of this leadership in managing stress amongst self and staff members is to be reminded of the body language aspect. You know, so there's always things about verbal encounters, pressured speech. Sometimes somebody will go quiet. Maybe somebody who normally has regular eye contact and communication is now, downward gaze. This certainly happened with one of my clinic managers who is transferring to another job, but upon the announcement, just didn't, whatever, the encounters were looking away rather than towards the individual. So I think it's really important to keep your finger on the pulse of folks. So like, if somebody does go quiet, is not as chatty. Conversely, if they're fidgety and just kind of like, pressure, doing a lot of things, like cleaning up aimlessly and not directed, that might be an indication of some form of stress. So everybody has a little different form. So like I say, some people become more of a turtle, withdrawn, and other people become the rabbit. They're hopping all over the place. The other thing that came up in our discussions, I forget which facility it was, but it had mentioned that some of the staff were reporting a lot of symptoms and illnesses, and they were going back into quarantine over and over again. That in itself, that recurrent pattern of sickness, while it might be real for whatever reasons, could also be an indication of stress. Those are some of the things to keep in mind. People pushing their neck, rubbing their neck, so if you see somebody at the workstation and they're constantly rubbing their neck, that could be a form of stress. The other one is space invasion. So this is always one of my favorites, like, how much distance do you need to give somebody before, you start backing away and, or whatever. And that space invasion can be a form of aggression. Believe it or not, I had a faculty member back when I was in Chicago who I always knew when she was really ticked off at somebody or maybe even me, because there was like 2 inches between her face and my face. She probably knew that I had garlic pizza the night before or something, but I knew I was in for a load full of issues when the space got invaded. So you can watch that and see that between the interactions between individuals. So does anybody have any comment about the video and so sort of the reflections of what it's talking about in your own facility?
Dr. J, I have one quick thought just related to stress. Now that there's been so many maybe additional tasks added on to some of the staff because of short staffing or just new requirements, whatever, I would encourage you guys to have your staff write out, this is my daily task list, and really look at it, because they could not be prioritizing the right way, which is taking more time, or they could be readjust the order they're doing it, like you're all in this space at one time and do these things. That's something that was helpful to me in the facility for CNAs and nurses on the floor, because we kept getting that they didn't have time to do it. They didn't have time. And it made it very stressful because they knew they needed to check all the boxes in the day. They didn't have time to do it. But once we reevaluated their task list, and then work together as a team, great PIP opportunity to recreate your task list and test it out in maybe one unit and then push it out to the others. It may be helpful.
Yeah, thanks, Kelly. That's really an excellent idea, in terms of just even if you had a PIP on team-based care, so for example, the interactions between the nurse and the CNAs. I was actually asking a family acquaintance who's a CNA here in Grand Forks about her routine in the nursing facility, and she was mentioning that they do have, with the CNAs, they do have huddles, and they do see the same patients. They have the same panel recurrently. I asked, well, have there been any moments of where you got frustrated, and there were. There was a list of things like moving a fairly heavy, large patient, and having one of the team members not really understanding the push and flow of transferring the patient or the right angle for the resident. My question was, well, did you mention that to the leadership? And she says, oh no, I'd never say anything like that. So there you go. Guess what? She threw her back out and she's out for 4 weeks. So, by not speaking up, because people feel like they may not have the agency or the permission to do that. And this is a kind-hearted soul. This is somebody that, really, really means good for her, her residents, and, just didn't feel like she had not necessarily the opportunity, but didn't have the place, right? Felt she was lower on the totem pole and just couldn't express herself. So I think that's an important part of quality improvement, is getting people comfortable enough to express some issues that, again, in this case, may have saved a slip disc that resulted from lifting a 300-pound patient. My goodness, even the Hoyer lift was groaning.
Yeah, that's a great opportunity once again for rounding. During your rounding, ask people some of those pointed questions. Do you have trouble transferring patients on a Hoyer lift? Do you feel everybody's comfortable with that process? And that's really where you can identify those opportunities for improvement and put some systems in place.
Yeah. Thanks, Kelly. And and I think it's just a reminder that, something that we take for granted, like, who would ask about transfer? Of course, we all know how to, transfer patients. And I remember as a younger doctor being schooled by a older nurse onto how to properly transfer a patient in bed from the bed to the gurney. And I've actually taught that to all my medical trainees going forward. Because, as a guy, you see a doctor trying to transfer a patient, they're out there trying to cradle them like a baby, as opposed to using the sheet, to, pull the person, and to be mindful that they don't, scrape or put pressure on those pressure spots at the same time. So yeah, some of those routine and mundane things need to be re-examined and just questioned as to how's it going, and were there any issues? So thanks for that. Maybe I can hand this off now to Michelle and Kelly for the quality improvement portion of this session.
Sure. Yep. I'll take it from here for a bit. So we're into step 12, the last step on that QAPI at a glance, which is take systemic action. And, the point of QAPI and these PIPs is not only that we want to implement change or corrective actions, but that we want that resultant improvement to keep going. We want to reduce the chance of this negative action happening again. And that can be really hard to accomplish. Our most common solutions that we throw into place and we have written on our 2567s are almost always provide more training or education. Our thought process is really about, asking people to be more careful. And that really doesn't change the process or change your system. These two solutions are based on the assumptions that lack of knowledge contributed to the event. And if the person was just educated or trained better, the mistake wouldn't happen again. And that's rarely what's at the root of the problem. We need to choose actions that are tightly linked to that root cause and then lead to a system or process change. So actions that simply support our current process are most often considered pretty weak, and they should not be selected as our sole intervention. The goal is to make changes that will result in a lasting improvement and avoid those quick fixes and weak actions. We need to eliminate those root causes, offer long-term solutions, and have a greater positive than negative impact on the process. Next slide. So what I'm sharing here is from the Department of Veterans Affairs, the National Center for Patient Safety, which classifies corrective actions as either weak, intermediate, or strong. And so we have at the bottom is the weaker actions. These are the actions that depend on staff to remember their training or remember what's in the policy. These actions usually just support your existing processes. Some of those examples can be double checks, warnings and labels, new policies, memos, more training or education, not necessarily bad things, but very weak on their own. The next step up is the intermediate actions, and these are somewhat dependent on staff remembering to do the right thing, but they provide additional tools to help staff remember or to promote clear communication. They modify an existing process, and some of those examples are to decrease your workload, make software enhancements or modification, eliminate or reduce distractions, add checklists, cognitive aids, triggers, or prompts, Eliminate items or references that look alike or sound alike. Using teach back will help in this area. Is considered an intermediate action. Enhancing your documentation and communications, building in redundancies. And the third category is those stronger actions. And those are those actions that are not dependent on staff trying to remember to do the right thing. This might not totally eliminate your vulnerability, excuse me, but it does help provide some strong controls. Strong actions change or redesign the process. They help detect and warn, so there is an opportunity to correct the problem before the error reaches the resident. They may involve hard stops, which won't allow the process to continue unless something is corrected, and that gives the chance to intervene to prevent significant harm. And some of those examples of strong actions can include things like physical change, like adding grab bars or non-slip strips to a tub or shower, forcing functions or constraints. And that would be something, when you look at your oxygen tubing and gas lines, that oxygen can only be connected to oxygen lines. It can't be connected in with a gas line, thankfully. But the reason that is that way is more than likely something negative happened at one point, and this is a strong action to avoid it from happening again. When your electric medical records don't let you go on any further, they've got those forcing functions in there. You need to go back and fix this before you can go on in your charting. Even things like, when we've gone to unit dosing for medication, that makes it a tangible, more stronger action. Next slide. So we have been talking for the last 12 weeks on how to make changes, which is great, but we also want those changes to stick. And the elements that help sustain improvement include having adequate data and accountability systems. The more current the data, the more useful. Data that is 3 months old or older, which is often the case with our MDS quarterly data, or heaven help us if we are using Care Compare data, which can be a year to even 18 months behind. Your staff is not going to take that seriously, and they'll often dismiss this isn't a problem anymore. Who knows if that's applicable anymore? But data from last week is taken much more seriously. It's much more useful to design your system so that the data is compiled, analyzed, and provided to those who use it as often as possible. Facilities that are able to do this on a more frequent basis, such as even weekly, have a much greater success with staff taking ownership of outcomes, which is vital for accountability. Data collected at the level of the unit or the shift or the department is much more useful in determining the source of the problem. So for example, just hearing that toileting is not being done, at your staff meeting does not have a whole lot of impact on a specific group. But on the other hand, if you have an audit data that shows that Unit C, evening shift, doesn't seem to be toileting residents because that unit has consistently much more heavily wet incontinence products and a lot more skin issues, that might lead to a different approach addressing the problem and some greater accountability. And Kelly has a story that she wanted to share with us along these lines.
Yeah, thanks. Thanks, Michelle. At the very beginning of Michelle's presentation, the first two questions were, did lack of knowledge contribute to the event? And if the person is educated or trained, will the mistake ever happen again? And so when I read her slide presentation the other day, a quick example popped in my head. One of the last facilities I worked at, we were conducting a chart audit. And while we were conducting this chart audit, we determined that the infection control assessments were not done for new orders for antibiotics. And in my head, I say, well, ADON Cindy, for example, is supposed to check these every day. Whenever she comes in the morning, she looks at the orders, she checks to make sure that the system is in place and that we're monitoring these folks on those antibiotics. Well, was she aware that this was a duty? Absolutely. She knew it was her responsibility. She had a time in the day that she had set up that she was going to do it. But it was very evident that that was not done on a daily basis. So once we looked at it and we had a conversation with this ADON, she goes, I really just I run out of time. I come in the morning, I come to the morning meeting, and I get hit with a million things. And then it just slips my mind. It ends up on the bottom of my checklist to do for the day. So as a team, we decided a better approach is to have multiple people kind of looking at this same system. And the way we did that is that morning, the ADON was still responsible for going and scanning the orders before the morning meeting. And say we had 3 people that started on antibiotics the day before, bring those charts along with the computer, because most of you probably still have a mix of electronic records and paper charts, right? Bring their charts as well as the computer to the morning meeting. And during that meeting, as a team, we were reviewing. And we created a war board. On this war board were like our key things that we needed to make sure we followed up on a daily basis. So anybody who was on an antibiotic went on the war board. And those charts would come to that morning meeting every day until we could confirm the infection assessment was done, as well as they have completed their antibiotics. Documentation was completed on how they were progressing. And it was a great opportunity for the team to do it. And what happened was actually a benefit because it took no more time. Our morning meeting wasn't any longer. The nurses came in to give report, and we talked about these folks on antibiotics. And so it was a trigger to remind the nurses that, hey, you have these people on antibiotics. How are they doing on the antibiotics? Are there any reactions? This assessment was done, etc. So my point being is, even though we always probably immediately go to, oh, we need to train somebody, that may not be the case. The ADON was perfectly aware of what the responsibility was, but they just didn't have the time in the day. So we basically took time out of her day, and we were able to do it as a team in that morning meeting, and it didn't really add any time to our daily meeting. So definitely anytime that there is a glitch or something pops up, take a look at the system, or as I mentioned earlier, look at their task list for the day. Is it realistic to think that that can be a line item in their task list, or can you plug it in somewhere like the morning meeting where it's going to take about 3 minutes because you have a whole team there to do it, or take 30 minutes for that leadership nurse to sit at the nurse's station and try to concentrate and complete that task.
That's great. Thank you so much, Kelly. Great example. One more slide here, to the next one. And this fits in exactly with what Dr. Jurevich was talking about, that just culture. This is an essential element needed to keep moving towards improvement and sustaining improvement. Just culture, or a culture of safety, or whatever your facility calls it, is just creating that atmosphere where people have the confidence to report safety concerns or any issue that they have without fear of blame, including if not everybody knows appropriate lifting strategies. Employees must know that their confidentiality will be maintained if that's something that they want. Their fear of other staff being upset with them, and that the information that they submit will be acted on. Otherwise, they will decide that there is no benefit in their reporting. And so it's just funny that this fits in exactly with what Dr. Jurevich was saying earlier. So I'm glad we threw that in there. Anything that anybody wants to discuss on sustainability or any of these things, just please feel free to unmute or throw them in the chat, and we can talk about them. We also want to get to where our progress is with our social isolation PIP. So we can go on to our next slides here.
Yeah, Michelle, I'll just throw one more thing in here on this slide, is that, the more that the staff try to promote them taking the initiative to bring you something. A conversation I used to have all the time is, thank you for bringing me this concern or issue. What do you think is going to be the best resolution for it? And then if we use their suggestion, if it's something that is reasonable, not like, hire 30 more staff. If it's something that is reasonable, then make sure that you share that with all staff. Cindy brought me this concern. This is what was going on, and this was her suggestion for improvement. And then it's kind of a trickle effect. Once you show that is the culture of your organization, then everybody else will start coming to you with their ideas. Hey, I noticed that this was an issue. Can we consider doing meal service this way? And then test it 1 unit, and see if it's more successful. But it's kind of a trickle effect once one person gets that kudos or recognition.
Definitely. Okay, Sarah, if you want to, or Casey, or who's ever doing slides, maybe we're going to just have a little bit report out. The next slide is actually Wishick. They did send in some data. So we'll just go to that one first, to the next slide there. I'm not sure if Cindy is on, but I saw Melissa. If you want to just share with some of the, I see that you did another loneliness scale. And why don't you just share with us what you found with this review?
Okay, so Cindy is gone today, so I'll just talk a little bit about it. We did notice for the most part, we did see improvement in our scores overall. Unfortunately, with a couple of the residents that got worse, some of it's just personal issues, health issues, things that even though we change things here, it's not going to change their personal loneliness or their feeling. One of the comments that one of the residents made during the interview was just that her family never comes to visit. And despite encouraging family to come, they still just aren't making those appointments to come for those visits. And we've even offered like an alternative time that we have time set from this time to this time. But if you're interested in coming on an off hour, we'll make it work for you. And it just doesn't always work that way. And so some of it is just those personal feelings that we don't have a lot of things to change there. As far as things that we did do to change to see overall improvement is our activity staff has moved some of their one-to-one visits either outside or even just outside of the room, because so much of this COVID isolation especially has been keeping people in their rooms. And for a really long time, we were even serving meals in rooms and they could only do very small group activities. And so trying to kind of get back to normal again and getting people out of their rooms more and more. And then just over this past week, we have a golf cart that can seat between 6 and 7 residents on it. And with the new guidelines now with masks and allowing people who are vaccinated to sit together without masks on, we are able to utilize that a little bit more than we could in the past. And so even just Monday, our activity director was able to take a couple of residents over to one of the memorial services at the park. And they were able to see their family at that service and, just different little things like that, it's nice that some of these changes are being made throughout so that we can make little changes here to try to make things just a little bit better. So I think we'll just continue to see improvements. Like I said, we'll always have those couple people who have personal issues, health issues, that they're going to have those feelings despite what we do. But if we can change it for a majority of the rest, I think we're making good progress.
Hey, Melissa, this is Kelly. I have a quick question for you. Do you have any consistent family members that come to see their residents, and do they have any interest in volunteering to spend some one-on-one time with other residents that don't have families that visit?
That's a great question. We do have a couple family members that probably come about once a week. I don't know if there would be an interest in visiting with others. I guess we haven't really thrown around that idea, but that would certainly be an option if, if some of those others don't have families that come, that might be an option for them too. That's a good idea.
Yeah, that's great. I love to see, overall, your totals did go down. When I got out my calculator to actually figure it out because I couldn't tell by looking at it. But yeah, I went from 67 to 53, which is a marked improvement. My real question is, do you think that you'll probably maybe do this again, maybe one more time, just the scale, or what is your thought process for the actual going forward?
I have to look ahead. We do have it scheduled around July 12th. We're going to repeat those interviews one more time just to see if we're continuing to make progress and just to make sure we're not sliding back in that direction either.
I think that's great. And I think that's a good time limiting thing. We are seeing the improvements unless we see something hugely significant, which I would suspect you would see before you do the, your scales. But that has been one of the discussions is, we don't need to go on with this for forever, but we knew that this is a problem. We're looking at it, we're addressing it, and we have the numbers to kind of support that. So thanks so much for sharing all of that, Melissa. Anybody else have anything else to share or questions?
Well, Don Jurovich here. Yeah, outstanding, Melissa. Congratulations. So it's also kind of interesting to look at this type of data, because the thing that strikes me are the outliers, the ones that have scored really high on the score. And, it makes you wonder, are there some common issues about those individuals? And I'm also reminded, back in my hospital days, of what I call the queen bee effect, that a lot of times there would be an older matriarchal mother or whatever of a large family who took to bed, and we couldn't get her up out of bed because this, woe is me, I'm sick, and summon my children, they must come visit me. So it was kind of like a psychological whatever impact, to actually be much sicker than she was, to evoke sympathy. And that was her, and we had to deal with that. So it just, again, reminds me of these instances where some people have greater needs than others. But also, the important part of your data is, like I say, it suggests that there might be, small subsets of individuals who then now what you would do is then think, well, is there a common thread here? Like, because you said, these people that they were special cases. So what is it about those special cases in discussion that you can identify, and then perhaps then have yet another PIP, or Plan, Do, Study, Act cycle rather. So this is the PIP, the Plan, Do, Study, Act cycle would be, say, we're going to look at the outliers, and we're going to do these kinds of activities with them. So like Kelly said, maybe having a volunteer little brother, little sister program or something to that effect. Mm-hmm. So yeah, this is just very powerful stuff, and it can really drive, and it's a handful of data, right? And so I just want everybody to recognize the fact that, you've got, about 12 or so patients or residents there. It's not a big number, and it's all these things that you can then do with this impact to say, okay, we're going to now disseminate this facility wide, and then perhaps do an assessment on at a later time on another unit to see if the durability of your intervention is persisting and having a favorable impact. So yeah, just a little bit. Well, I don't want to say a little bit of effort, but again, congratulations on putting this together, and it really goes a long way in discussions with the QAPI committee and with the staff. You can share that with the staff. They may go, huh, what changed? Then all of a sudden you say, well, we've got this one-on-one visit program going, and they go, oh yeah, and this was our PIP. So now they know about it, and they say, so when you do your next survey with your walk rounds, what were the results of our most recent PIP? Everybody says, oh, people aren't as lonely as they used to be. And, so just acknowledging that and celebrating and again, congratulating on the positive effect. And that really gets people pretty upbeat, knowing that they sharing those successes with the staff, that you guys are truly making a difference. And that's part of acknowledging staff that they're doing a good job, and they say, what are they doing to reduce this loneliness? And it's like a little bit more one-on-one time that's making the difference. And so maybe people will start incorporating that into their routines in addition to the set-aside program that you created. So that's wonderful. Back to you, Michelle. I think you have another PIP.
Yeah, I see Allison is on. And she was just going to share both for Rosewood and for Missouri Slope. They were just going to share with us a verbal update. So Allison, are you available?
Yep, I'm here. So I just kind of got an update. We're still kind of working through implementing the interventions that we identified to address the isolation and loneliness. So we've initiated 2 new activities. One is a tour of the United States. So each week they pick a different region or state to go to, and bring a group of residents, including the 12 residents that we interviewed in those groups, and just try to create an environment where they can kind of talk with each other, get to know each other, form some bonds and some good communication with each other to combat that feeling of being alone. And then the other one we added was a movie. So they would watch a movie on Monday afternoons and have popcorn and root beer. So just bringing people together now that we're able to do that. So it sounds like most of the residents that have been coming to those activities have been enjoying them. It does sound like a couple of the residents who were in that 12 resident group who were interviewed have not been coming. And so I have asked them to do follow-up with those residents to find out why it is that they're not coming. Just because if it's the activity that they don't like, maybe we need to find something different for them, or what the reason is behind that. So we're still kind of working on those things, and we'll be re-interviewing those 12 residents. We meet again next week, so probably the following week we'll do those interviews again and see where we're at with their numbers. Another thing that we just had gotten some information about is the social isolation and loneliness community program. This was from Jeremy Holloway at UND, and geriatrics reached out, and they're doing some interviewing. Students are doing WebEx or phone conversations and looking at loneliness and isolation in older adults. So we may utilize that too, as doing some more one-on-one conversation with our 12 residents and others if necessary. It sounds like it's training the students on the skill of listening, and then also empowering the residents to share stories of their past and any wisdom they might have to share with them as well. So just trying to get them to open up and create some more conversation and bond where they won't feel like they're completely alone. And I know we have some residents who don't have family that visit a lot, so maybe try to focus those more one-on-one visits with those residents so that they are getting those good focused one-on-one visits. So that's kind of where we're at right now. Don't have any numbers to share, unfortunately, at this point, but we'll keep working on it.
Yeah, thanks, Alice. I was going to just mention the reminiscent therapy or the storytelling that our UND faculty member, Dr. Holloway, is doing. Really is a very powerful mechanism for reflection. Interestingly, that whole project is hopefully being transported into Indian country with Spirit Lake in particular. They were reflecting on the fact that they had lost quite a few elders from the pandemic, and so they wanted to really get a fairly rapid documentation of the legacies of their surviving tribal members, and so they're applying Dr. Holloway's program there too in the near future. So that's great. Michelle, did you have Missouri Slope, or were they going to do next time?
They don't have any updates for right now. They have a meeting set later, it looks like, so maybe we'll catch them next time. That project, the Reminiscence Project, is that something that other participants in our ECHO group could reach out to you or Dr. Holloway about, if that's something that or are you tapped out with?
No, I honestly don't know. It's only in proportion to the number of students that sign up and can do the interviews. So from my perspective, sky's the limit. Yeah, I'll have to defer to Dr. Holloway as to what his capacity is for, for doing this. But yeah, to be encouraged. So if you do want, just get in touch with us, and we'll make the connections with Dr. Holloway to do the, like I say, the reminiscence therapy, basically. They provide a little booklet, so the students will interview, get the resident history, and then create a small booklet for the resident or their family members. So
That sounds just great. So it looks like we're almost out of time. I will defer it back to you guys.
yeah, okay, good. So we're still promoting the one-on-one sessions here. If you want to have a set aside with your QAPI team to have a discussions. Again, we'd like you for next week to think about the kind of your reflections on what worked and what may not have worked for your PIP on social isolation. Quite honestly, if you didn't get traction on it, that's a reportable thing for us, right? Why what were the barriers to getting traction on that? And then moving forward, I'd like you to think about the root cause analysis for falls. So again, if this week, if you can start to assemble an assessment for a root cause analysis, either using the fishbone or the 5 whys, that you look at the geography of where most of the falls are happening. Is there a pecking order in the geography? Time of day, and then location within the facility. Is it occurring primarily in bathrooms, bed transfer, dining room, and so forth? So those are the kinds of things that would be helpful. Other things to reflect on for the fall PIP is whether everybody is getting some supplement of vitamin D or not. So that would be part of your root cause analysis. And then also if they have any type of core balance training as a routine for that. And we'll send out a few more questions that you might want to ask about your fall prevention program. So anyways, I just want to get everybody stimulated and thinking about that.